Good morning, good afternoon, good evening, everyone. I welcome you to today's webinar on thought-provoking perspectives on child stunting. My name is Cornelia van Zyl. I will be your moderator today. I am the Senior Technical and Policy Advisor at the International Food Policy Research Institute, or IFPRI, in support of the National Information Platform for Nutrition, or the NIPN in Ethiopia. Now, before I start, I just want to make one announcement, and that is my internet is a little bit spotty. So should it fail, I will hand over. I will switch off my webcam and continue with my audio. And should that fail, I will hand the moderation over to Chris Rue. He's the Senior Program Manager for the Compact 2025 initiative. Also be reminded that this webinar is recorded today. It is also co-organized by the Ethiopian Public Health Institute, IFPRI, in support of the NIPN. So for the past decade, we've seen unprecedented attention going to undernutrition. Drastically reducing child stunting has become a global development objective. The focus on linear growth retardation and stunting led to successful advocacy for nutrition. But it also revealed confusion and misunderstanding about the meaning of these terms among researchers, donors, and agencies active in nutrition. Today's webinar will have two key presentations. The first will be based on a critical review of literature and will challenge current views on the consequences of linear growth and stunting. It will call for fundamentally different ways of using linear growth and stunting as measures of global development. The second will present a significant but underappreciated additional factor to child growth faltering, namely altitude. Analyzing data from nearly 1 million children across 59 low and middle income countries, the study will share key insights into the association between child growth faltering and residence at high altitude. So we're very much looking forward to these timely and interesting presentations. Please remember to put your questions in the question box on the right side of your side panel. Maybe take the time quickly to look at where that is. And at this point in time, I would now like to introduce Dr. Aregash Samuel. She is the Deputy Director for the Food Science and Nutrition Research Directorate at EPHI. She's also the coordinator for the NIPN in Ethiopia, and she will give us her opening remarks. Over to you, Dr. Aregash.
Thank you, Cornelia, for the introductions. Greetings to all our participants in today's webinar. As Cornelia already told you, I'm coordinating NIPN Ethiopia. To just give you highlights about NIPN, the National Information Platform for Nutrition, it's a global initiative supported by European Union Delegation for Ethiopia, with support from the Foreign and Commonwealth Development Office and the Bill and Melinda Gates Foundation to support scaling up nutrition countries that have a high burden of malnutrition. NIPN is actively ongoing in 9 countries globally, Ethiopia being one of those countries. The technical support for NIPN Ethiopia is provided by the International Food Policy Research Institute. NIPN Ethiopia was established in 2018. The NIPN aims to support evidence-based decision-making for nutrition and consists of 3 operational elements, namely the policy question formulation, the identification and analysis of data, and the communication and outreach of research findings. In line with the 3rd element, NIPN organizes seminars like webinars of today, newsletters and blogs and so on. Due to the current situation, we have changed our approach to make it a virtual one. During the COVID pandemic, for example, today is our 4th event. So NIPN has been seeking innovative ways to inform decision makers by tapping its existing partnership and by taking advantage of webinars to reach a large audience. As such, NIPN has organized the first seminar on COVID-19 together with IFPRI on May 14 on the impact of COVID-19 and the prevention measures on Ethiopia, focusing mainly on food and nutrition security, the economy, the feasibility and prospectus of some prevention measures for nutrition and health, and on the agriculture value chain. That event was very successful. Again, on May 29, we had hosted our second webinar on the role of vitamin D in treating COVID-19 patients based on the current scientific evidence. That was also supported by our research partner, the University of Saskatchewan, Canada. That event was also attended by many stakeholders. Thirdly, on September 23rd, we had also another webinar on the title Economic Shocks and Child Wasting. Today's event is the fourth one in this series. Therefore, our webinar today is on thought-provoking perspectives in child stunting. More importantly, we would like to continue bringing the current issues to the nutrition stakeholders' attention. Therefore, we will have our another webinar, which means the fifth during the COVID, on December 9 from 4 to 5 p.m. at this time on the title Dietary Transition in Africa and its consequences to the rise in non-communicable diseases. So stay tuned. We will keep you informed. Welcome and thank you all for being with us today. Now I'll pass on to our moderator. Back to Cornelia. Thank you.
Thank you very much, Dr. Aregash, for your opening remarks. We certainly are looking forward to these presentations as the time is ripe for them in Ethiopia. I would now like to call upon our first speaker, Dr. Jeff Leroy. Dr. Jeff is a Senior Research Fellow at IFPRI's Poverty, Health and Nutrition Division. Dr. Jeff has a PhD in International Nutrition from Cornell University in the US and an MSc in Agricultural and Applied Biomedical Sciences from the University of Ghent in Belgium. Dr. Jeff studies the impact of nutrition-sensitive agriculture and social protection programs on maternal and child health. His work spans multiple geographic locations in Asia, Africa, and Latin America. His research work is very diverse, so I'll just show you some of the things he's doing. He is currently working on an evaluation of the social protection program in Bangladesh, which is designed to improve birth outcomes. He's doing an evaluation of a training and certification program aimed at improving the quality of milk sold by informal vendors in Kenya. He's also studying the role of food environments in adolescent nutrition in urban areas in Ghana, as well as the use of child linear growth and development, hence also today's presentation. He has published in many scientific journals, and he's also a member of the expert advisory group for the Global NIPN initiative. With this short introduction, Jeff, I now hand the floor to you.
Thank you so much, Cornelia, and many thanks for the invitation to be part of this exciting symposium on child linear growth. The work I will be presenting today was conducted together with my colleague Ed Frangillo at the University of South Carolina. On the next slide, if that could be shown, I want to start with some definitions to make sure that we're all on the same page. And what I'm trying to show here is that there is a difference between growth retardation and stunting. So let's start with the red distribution, which is the distribution of healthy children, the growth standard. As you can see, the mean there is around 0 in terms of height for age z-scores. The blue distribution, which is shifted to the left, is from a study we conducted in Burundi. And as you can see, the entire population of children has shifted to the left. So we can safely say in this population that all children suffer from growth retardation. Now, only 60, well, not only, but 60% of those children are defined as stunting because their height for age z-score happens to be below the -2 cutoff. So there is a difference between what stunting means and what growth retardation means. The motivation, which you can see on the next slide, is that we've seen in the last decade an unprecedented increase in attention to undernutrition. And within that focus, child stunting has become an important, or reducing child stunting has become an important objective globally. And the strong focus on stunting has clearly enabled us to be successful in advocating for nutrition. But at the same time, there is a downside that it has led us to some confusion and misunderstanding about what linear growth retardation actually means. The concern we have, and this actually was the motivation for this work, is that we might be overselling the importance of stunting. And by overselling stunting, we might be drawing attention away from the more important problems. And we believe the cause of the confusion is really a poor understanding of the difference between two different things. And one is growth as an important outcome, and growth as a marker of something else we're trying to measure. And on the next slide, I'll try to start with a simple example of what I actually mean with the difference between an outcome versus a marker. This is a story by Roald Dahl, Esio Trot. If you haven't read it, it's a children's book. It's quite marvelous to read it. So it's about a Mr. Hoppy. He's a shy old man, and he's secretly in love with Miss Silver. And Miss Silver lives one floor below. Miss Silver has a small pet tortoise, and the name of the tortoise is Alfie. And she really wishes she knew how to make Alfie grow. So on the next slide, we can see what Mr. Hoppy does. Mr. Hoppy thinks of a creative solution. He gives his neighbor a piece of paper with some secret language that she has to whisper in the tortoise's ear every day to make it grow. But what Mr. Hoppy does, he secretly goes to all of the pet stores in town and he buys every single tortoise he can find. And every day when the neighbor is gone to work, he picks up the tortoise on the balcony and replaces it with one that is just a tiny bit bigger. And that way, the neighbor thinks that her tortoise is growing. On the next slide, we take the story apart. We're not here for storytelling, we're here for science. So as you can see here, what I'm trying to show on this slide is that the theory of change for both of these individuals in the story is different. For Miss Silver, she looks at Alfie's growth as an outcome of interest. She thinks, I say these secret words, and then Alfie starts to grow. For Mr. Hoppy, it's a bit different. He knows that when she says these secret words, I need to swap the tortoise, and then her trust in me and ultimately her love for me will increase. So for him, Alfie's growth is a marker of trust, a marker of her love. It's not an outcome of interest in and of itself. On the next slide, I just want to quickly say that we're obviously not here to talk about tortoises or the growth of tortoises. We're here to talk about child linear growth. So let's start to look at some literature on the next slide. This is just taken from a number of publications, and it's quite easy to find these types of statements. And what I'm trying to show here is that in the literature, we find a lot of causal claims when it comes to linear growth. So very often we say that stunting has impact or has effects or leads to things like reduced educational attainment, health, non-communicable diseases, economic productivity, and so on. And just to quantify this issue a bit, in a recent comprehensive review that was published in the International Journal of Epidemiology in 2017, over half of the 68 papers on linear growth made these types of causal claims. Now, as you can see on the next slide, you can summarize what these articles, many articles, are saying as follows. Linear growth retardation causes, they use causal language, 5 broad types of outcomes. It leads to reductions in child development. It leads to reductions in work capacity. It leads to increases in chronic disease. It leads to problems with encephalopelvic disproportion, which means that the child's head is too big for the birth canal, leading to difficulty during birth. And it also leads to poorer birth outcomes in the next generation. So stunted mothers have smaller babies in the next generation. So that is what the literature says, that linear growth retardation causes these 5 broad areas of problems. If we can see the next slide. Okay, so the world has really heard us nutritionists say this. The causal claim is very strongly embedded among agencies and donors active in nutrition. There's this widespread adoption of the view that stunting leads to developmental delays, lower level of schooling, and so on. As a consequence, linear growth retardation and stunting have become primary development objectives. And there's a general belief that when we eliminate stunting, will automatically lead to meaningful benefits in a large number of other domains. Now, the question is really, is that true? Is that a good expectation to have? Let's go to the next slide. So what the causal thinking implies is that this is the framework I've shown before. What now happens if we remove linear growth retardation? Can we see the next slide? Okay, so if we remove linear growth retardation, and I indicated this with the green cross, rather than having all of these problems, we should now see improvements in child development, in work capacity, reductions in chronic disease, and then improvements in issues related to size at birth and difficulty during birth. But is that really true? Can we see the next slide? What does the evidence say? And what we did here is we went to the literature, and for each of these 5 domains, we carefully reviewed what the literature says. And you'll have to believe me, I don't have time to present all of this evidence, but you can find it in the article that I will share with you at the end of my presentation. Can we see the next slide? So this is what the evidence says. The evidence shows that there is no reason to believe that linear growth retardation causes the first 3 outcomes. So the reduction in, or the problems with child development, the reductions in work capacity, or the increase in chronic disease. There is evidence that it's causally linked to the difficulty during childbirth and with having smaller children in the next generation. Next slide. One thing before I move on that is very important and where I found there is sometimes some confusion when I present, the evidence on causal effects that I'm presenting relates to linear growth retardation and stunting. I'm not making these claims about undernutrition. We do know that undernutrition causes, for instance, problem with child development. I accept that, and I'm not questioning that. What I'm presenting here is that linear growth retardation does not cause these types of problems. Okay, on the next slide, I want to present how we now use this evidence to change our thinking. This is what I've shown before. Can we see the next slide? And this is what I propose as a new framework. And this looks a little bit complicated, but I will walk you through this. So let's start at the bottom. We now have established that linear growth retardation causes these 2 problems. So it's causally linked to these being small at birth and difficulty during birth outcomes. Now, what about the other outcomes? Well, we know that linear growth retardation is a consequence of a deficient environment. That means an environment that does not provide the right nutrients and good health for children to grow and to develop. So that's a causal link between the blue box and the red box. We also know that these deficient environments, they cause problems with child development, they cause problems with reduced work capacity, and they also cause problems when it comes to physiological functioning and non-communicable diseases. So where does that leave us? Linear growth retardation causes the 2 problems at the bottom, but at the same time, we can use it as a marker or an indicator. It's a marker of the past, and that's that dotted gray line that you see. It tells us something about how these children grew up and that they didn't have the conditions necessary to grow and to develop. And it also tells us something about the future. It's a marker of the future. It tells us that when children or populations of children suffer from linear growth retardation, that their development, their work capacity, and their physiological functioning is unlikely to be where it should be. So in summary, it causes 2 outcomes. It's a marker of the past, and it also is a marker of the future. On the next slide, please. Now, this is another way to look at it. And we know that if there is a fire in your house and the smoke alarm starts to go off, make noise, we call the firefighters. And what we want the firefighters to do is to extinguish the fire, which is the cause of the problem. We do not want the firefighters to just come and turn off the smoke alarm. That would not be acceptable. So we need to think of linear growth retardation a little bit like a smoke alarm. It's something that tells us that the situation is not good and that there will be problems in the future. But it's not the problem that needs to be addressed. The problem in this example is the fire that needs to be extinguished. Next slide, please. Okay, what I showed on that previous picture is that last year I presented this at Wageningen University, and when right after giving the smoke alarm example, the smoke alarm in the building went off and everybody had to leave the building. So I'm not sure whether my presentation was related to that happening. Now back to the serious work here. At one occasion when I presented this, somebody said, what you present doesn't matter. Whatever is good to reduce stunting is also good for other outcomes. And I think there's three important reasons to disagree with that. First of all, improving linear growth is often not necessary. We do not have to fix growth completely to have significant and also meaningful impacts on important outcomes. Next. Another point is that improving linear growth is often not sufficient. If you, for instance, imagine a well-growing child with anemia in an environment lacking stimulation, it is unlikely that child will develop properly. So having good growth is not sufficient. And then the third point I want to make here is that improving linear growth is often not cost efficient. What I'm trying to say here, that addressing outcomes directly is more efficient than trying to address them indirectly through linear growth. For instance, when you think about obstructed labor, it's much more efficient to prevent that through better care at birth than waiting a generation for girls to become taller. Next slide, please. So another consequence of what I'm saying is that a single focus on stunting has unnecessarily downplayed the importance of interventions that only improve infant and young child feeding practices, dietary adequacy, water hygiene, and sanitation. So what I'm saying, these are all very important outcomes. And if we can improve these outcomes, but have no impact on linear growth retardation or stunting, we should be proud of those accomplishments. Another issue is that a single focus on stunting may undermine efforts to engage other sectors in nutrition-sensitive programs. For instance, the agriculture sector, they are happy to work with us to improve diets, but they should not be held responsible for improving linear growth. And then finally, an important topic as well, and we don't have enough time to go in depth here, but there is also some sort of a sense of fatalism. That little or nothing can be done after 2 years of age. We know actually that growth retardation continues beyond 2 years. And more importantly, we know that many interventions in other domains, for instance, early childhood development, can still make an important difference after age 2. Next slide, please. So how do I propose we move forward? First of all, we need to be very specific. Undernutrition is not the same as stunting, and stunting is not the same as linear growth retardation. So we have to be very clear about what we're trying to accomplish, what we're discussing, what problem we're trying to address. And we need to be explicit about reasons for focusing on stunting. Is it for population assessment? Is it to count those who are affected, and so on? In programs, if it is used just as a marker of another outcome, or is it used as an outcome of immediate interest? Those are things we need to think through more carefully. For population assessment, the last bullet on this slide, it's a fine marker. I mean, it really tells us something about whether the population of children is doing well, whether they do have access to the resources they need to grow and develop. Next slide. But it should not be used to count cases. We use stunting to count the number of children, but that really has limitations. As I showed you on the first slide, in Burundi, for instance, the number of children suffering from linear growth retardation was a lot larger than the number of children who suffered from stunting. And then finally, for programs and impact evaluations, I do not think growth is a good primary outcome. As we've shown now, stunting is linked causally to only 2 outcomes, and those outcomes can be addressed much more effectively through direct interventions. So I would suggest that we focus on what matters and can sensibly respond to the intervention. We should focus on topics or outcomes like morbidity, dietary intake, food security, child development, and so on. Next slide. Thank you very much for your for giving me this opportunity. And I just want to say that at the end of the book, Mr. Hoppy and Miss Silver get married. So you should definitely read the story. I think there's one more slide with some information on where you can find the article. Thank you very much for your attention.
Thank you very much, Dr. Leroy. That was a thought-provoking presentation, to say the least. We've received a couple of questions already on what you've presented. So please be aware that we will do the Q&A session after our next presentation. I also saw the video on your last slide, and I encourage everybody to take 5 minutes to look at it too. It's a really good one. So I'd now like to take the time to introduce our second speaker, Dr. Kaliab Baye. Dr. Kaliab is an Associate Professor of Human Nutrition at the Center for Food Science and Nutrition at Addis Ababa University. He holds a PhD in Nutrition and Health from the University of Montpellier in France. He also holds a Master in Food Science and Nutrition from Addis Ababa University. His research interest is on maternal and child nutrition, micronutrients, dietary intake assessment, and interventions to improve diet quality. He's published in a variety of journals, but not only does he publish, but he's also the Deputy Director of the journal Public Health Nutrition, published by Cambridge University Press. He's a member of the editorial board of the journal Global Food Security, published by Elsevier, and is Associate Editor for the journal Biomedical Research International. He currently serves as Deputy Secretary for the Africa region for the World Public Health Nutrition Association. So that is a mouthful, but now, Dr. Kaliab, the floor is yours. Over to you.
Thank you, Cornelia, for that wonderful introduction. Good morning, good evening, good afternoon, depending where you are. I'll be presenting on our study on the evaluation of linear growth at higher altitude that was conducted in collaboration with my colleague, Kalle Hirvonen from the International Food Policy Research Institute. On the next slide, as an introductory remark, I would want to highlight, and as also mentioned earlier, that stunting is now being used as a development for tracking development programs, as well as, for example, for the World Health Assembly in the 2025 target is to reduce stunting by 40%. Similarly, for the Sustainable Development Goals under goal SDG 2, which aims to end all forms of malnutrition, it's been used to track progress. But progress is routinely measured using anthropometric indices, that is height for each Z score, that compares child height to the WHO growth standards. So in the next slide, I want to show you that the use of height for each Z score to and then stunting as an indicator of development came from the understanding that children anywhere in the world, if given if given the right, if they're growing in the right environment, and also their physiological needs are met, they would grow, they would reach their growth potential. They have the same growth potential irrespective of their genetic makeup. This was established by the WHO Multi-Center Growth Reference Study, which is the origin of the development of a prescriptive growth standards for children less than 5 years of age. The WHO growth standards that we're using to define whether we have in a population the magnitude of stunting and so on and so forth. But if you look closely in some of the methodological papers of the MGRS, the multi-growth reference study, you would see that in selecting sites from different regions, there was a deliberate exclusion of sites that are above 1,500 meters above sea level. I would come to it why that could be the case, but then that leads to the subsequent question: is the application of the WHO child growth standard in high altitude settings justified, given that the sites above 1,500 meters were excluded? And so would then the conclusion that came from the multi-growth reference study equally apply to settings at higher altitude? On the next slide, I would So on the next slide, I would want to give you a bit of a historical perspective of studies that looked at the relationship between altitude and child growth. It has been a topic of interest since the 1950s. Among the first studies that looked at associations between child growth and altitude is the study by Lichi from the US in 1957 that reported that in Colorado, in high altitude settings, there was a higher risk of low birth weight. And then this was followed by subsequent studies, particularly the study by Yip in 1988 is the one that is cited to reason for excluding high altitude sites from the selection of study sites of the multi-reference growth study. But then, you know, the discussion goes on, and in 2001, a study by Harris was published in the New England Journal of Medicine. This study evaluated the child growth in the highlands of Tibet, so among Tibetan children, and then concluded that it's not really altitude per se, but it's all the associated environment, the harsh environment, the low diet quality at higher altitude, low production diversity, and so on, that is likely to be linked to the growth faltering and not necessarily the altitude. But to kind of summarize, the characteristics of earlier studies on the relationship between altitude and child growth are characterized by inconsistent findings. They often come from a single country and often have a small sample size. And for example, the study of Harris only considered a low range of altitude. So the altitude range was quite narrow. It was from 3,000 meters above sea level up to 4,000 meters above sea level, which would consider high altitude anyway. So there was a limited chance to compare it to residents at a lower altitude. And then potential confounding factors were not accounted, were not fully accounted. So the discussion goes on. It's not concluded yet whether altitude has an effect or not, but it has been put on the side because it was excluded. I mean, the decision was made to exclude it from the selection of the sites of the MGRS, which is fine because the objective then was to make sure, or was to answer the question of whether children under a certain home environment would be able to grow equally, irrespective of their genetic makeup. So for that specific question, the fact of excluding higher altitude sites, given the inconsistent findings, is quite justified. On the next slide, I would want to show you that it is less so justified to exclude high altitude sites, given the transition that we've made in using height for HZ scores as well as stunting as an indicator of progress made in the developmental sector. So, to be able to judge, one question that is of importance is how many people live at higher altitude, and so what would be the consequence of leaving out or not being able to answer whether the WHO growth standards apply to these settings or not. So in 2010, about 842 million people in the global population, that represents about 12% of the population, lived at altitude higher than 1,500 meters above sea level. And of particular importance, many of these residents live in Asia and Africa, which are regions that have a highest burden of stunting and growth faltering. On the next slide, so we, given the context that we have a number of, a big proportion of the world population living at higher altitude, not knowing whether the conclusion from the MGRS, from the multi-growth reference study, equally applies to high altitude or not, we thought, and also considering that stunting is now being used as an indicator to track progress on global nutrition targets and the SDGs, and countries are reporting to that, it is necessary to revisit the association between altitude and child growth. So in doing so, we also tried to then answer to the following two specific questions. One is, does residence at higher altitude increase the risk of linear growth faltering? And secondly, does the prescriptive WHO growth standard equally apply to children residing at higher altitudes? So to do that, on the next slide, we followed specific methodological steps. So we analyzed 133 nationally representative demographic and health surveys conducted between 1992 and 2018, which allowed us to get close to 1 million height measurements from 59 low and middle income countries, which represented more than 95,000 clusters, with elevations ranging from -372 to 5,951 meters above sea level. And we were also able to adjust for common covariates, including diet, disease markers, and underlying causes like education, maternal education, household wealth, WASH, and as many variables as we were able to control for, depending on whether it was captured in the demographic and health survey or not. And to do so, on the next slide, we followed the following three major steps. One, the first step is to use linear regression methods and quantify the child height deficit associated with altitude. That is after adjusting for confounding factors that we were able to control for. Second, we ran a multivariate regression models to assess how altitude is associated with immediate causes of malnutrition. These are diet and disease indicators captured in the DHS. So basically, you've got some of the IYCF indicators, dietary diversity, meal frequency, etc. for diet as a diet indicator, and for disease, you've got cough, fever, and diarrhea. Now, and at the third stage, we restricted the sample to children who resided in what is called an ideal home environment to then reassess the relationship between altitude and child health. I would come to what ideal home environment is and how it's defined later on. On the next slide, we also compared child growth trajectories above and below the 1,500 meter above sea level, which is the cutoff that was used in the MDRS, to compare how children grow by age in the two categories of altitude. We run multiple robustness checks that included climatic factors, precipitation, and so on, maternal height, residence in the same location since conception. We also run the regressions by omitting the low altitude countries, also by excluding each country individually to see if whether the relationship is driven by a single country or some outlying effects, and then also by using stunting as an outcome. On the next slide, so here's our finding, looking at on the y-axis, what you have is the height for HZ score, and on the x-axis, you've got child age and month, and the two curves are showing you. So in blue, you've got children residing at altitude lower than 1,500 meters. And in orange, you've got children residing above 1,500 meters above sea level. And what you see is, starting from the beginning of the curve, you would see that the children that are living at a higher altitude are born shorter, and then didn't show any signs of catch-up as they grew older. On the next slide, we are now comparing height for HZ score by altitude. And so this time it's to look at not just the cutoff of 1,500 meters above sea level, but to see the relationship between altitude and growth across a wider range of altitude. So what you see is it's the deficit, deficit that we've seen is not linked to a specific cutoff. You already see, starting from about 500 meters, a sharp decline in growth. And the relationship is more of a linear one, where you have, for every 1,000 meters above sea level increase in altitude, you have a roughly a decrease of 0.16 units, standard units decrease in height for each Z score. And that is after adjusting for common factors, the common risk factors. On the next slide. Here we show the relationship between some of the immediate causes of undernutrition in the UNICEF conceptual framework, some of the immediate causes of stunting. In this case, we looked at diet-related indicators that are captured by the DHS, as well as disease markers that were captured by the DHS. Of course, we are limited by what is available in the Demographic and Health Survey. But one important finding is the first three indicators on the table is exclusive breastfeeding, achieving minimum dietary diversity among children aged 6 to 23, and also achieving minimum milk frequency among 6 to 23 age old children. So on the right side of the graph, you would see that on these top three indicators, we're crossing the line of 1, which suggests that there is no significant relationship between these dietary markers, these dietary indicators, and altitude. Whereas for disease indicators such as diarrhea, fever, and cough, we see that there is a decreased risk of these disease with altitude. So if you have a reduced risk of disease, you would expect, or you would expect to see an increased likelihood of growing better, but that was not the case. On the next slide. We now try to apply the concept of ideal home environment, which was defined as a home environment that allowed children to achieve their full genetic potential. And a study by Kara et al., published in the American Journal of Clinical Nutrition, the same data set, the Demographic and Health Survey, was used to, by applying a strict criteria that would define ideal home environment, whether it was possible to have a gross distribution that matches the one from the WHO gross standards. So we replicated that, and so the criteria for defining ideal home environment is the child is from a single birth, the household has access to safe water and sanitation, the household has finished floors, they own a TV and a car, children are born to highly educated mothers, so the highly educated was defined as more than 13 years of schooling, and then the child or children have received vaccinations such as BCG and DTP vaccinations. So in applying that ideal home environment criteria, we were able to have a gross distribution. So what you have in green is the height for age Z score distribution in our sample. And what you have in red dashed lines is the distribution that you have from the WHO gross standards, which is considered as normal. So you would see that if a child lives in, fulfills this strict ideal home environment criteria, the likelihood to have a gross distribution that is in line with the normal curve of the WHO gross standard is higher. But you would want to also take a note that on the footnote, you would see that our sample size decreased from close to 1 million to now 1,718. So it's quite a strict criteria, and not so many children in the world fulfill this ideal home environment, or they don't live in this ideal home environment. On the next slide. So now what we did, is by applying this concept and by defining the ideal home environment, let's select the children that fulfill that ideal home environment condition and plot their height for each z-score against altitude. And so what we see is, starting from about 500 meters above sea level, you see a sharp decline in height for HZ score, even for children that are living in an ideal home environment that was earlier proven to allow children to reach their growth potential. Next, please. So it's important that by restricting our sample to the ideal home environment, we're showing that it's not related to income or other factors. It is possibly a direct relationship, the direct negative effect of altitude. But it's important to understand now what could be the potential reason for altitude-related growth deficits. Now presenting back again this graph that I presented earlier. On the left side, so if you look at the circled one, what I want to highlight here is that children at higher altitude, at altitudes above 1,500 meters, were already born shorter than their lower altitude counterparts. And they followed that same, the gap didn't narrow, the growth trajectory, that difference that was there at birth was maintained as they grew older. So this is suggesting us that possibly the effect of altitude on child growth could be related to the perinatal period and perhaps to complications during pregnancy. And so going through studies that looked at relationship between altitude and pregnancy and adverse outcomes, you would immediately understand that, of course, at higher altitudes, the availability of oxygen is lower, whereas during pregnancy, your demand for oxygen is higher. So there's a possibility, there's a high risk of getting into what we call a chronic hypoxic situation. So where you have a constant deficit, where you're in a constant deficit of oxygen. So under normoxic condition, that is normal oxygen availability, you would expect a normal fetal growth and development, provided that there is adequate nutrition and so forth. But if you're in a chronic hypoxic condition, fetal survival comes first. So the child is in a situation, in an environment, the fetal is in an environment that is not favoring growth. And what is important here is to survive this environment that is suboptimal, that is not providing enough oxygen. And so there's a shift in priority. The priority would be to supply the available oxygen to vital organs, and in doing so, then growth becomes secondary. And so the fetus becomes smaller. And that's one way of adapting to the non-ideal environment, fetal environment, in a situation of chronic hypoxia. On the next slide. Okay, if this is somehow justified by the effect of chronic hypoxia and the relationship with intrauterine growth restriction, the second question, okay, they're shorter in height, so what? Or is it more than that? Is it more than the physical size that we are talking about? We would consider that it's just a physical problem, just being short. If you're able to have some form of genetic adaptation. But this has been mentioned in a number of studies that looked at genetic adaptation of living at higher altitude, to genetic adaptation to chronic hypoxia. And studies have indicated that to benefit from genetic adaptations, you would need to reside in higher altitude over multiple generations. And so 100 years, 1,000 years is not enough. You need to have ancestors that lived at a higher altitude. And even then, the compensatory mechanism by the compensation from genetic adaptation is only partial. A second point is hypoxia-induced intrauterine growth restriction is also associated with cognitive impairments, as indicated in previous studies, has been associated with abnormal cardiac functions. With the limited oxygen availability, one way to respond is to increase your cardiac output to get more oxygen, and in doing so, you can have some deregulations that could have lasting effects. And some have also linked increased intrauterine growth restriction to increased risk of chronic disease in later life. So it's not just a physical problem, it's also likely to be associated with functional deficits. Next slide, please. So the next one is, what's the magnitude of the deficit? Is it important? And is it biologically relevant? And to illustrate that, I'm showing two cities that are at higher altitude. On the left side, you have La Paz in Bolivia, which is situated at 3,600 meters above sea level. So based on our estimations of the gross faltering related to altitude, that would mean we have a deficit of 0.6 standard deviations in height for each z-score. If you're just by the fact that you're residing in La Paz compared to, for example, at sea level. In Addis Ababa, which is situated at an altitude of 2,355 meters above sea level, approximately, then you have a gross deficit that could be as high as 0.4 standard deviation. To put that in perspective, we looked at the study from Andrew Prentice that looked at retrospectively, 4 decades of nutrition-specific and nutrition-sensitive interventions that they've done in the MRC unit there at Geneva, and they attributed that 40 years of intensive nutrition-specific and sensitive interventions had allowed gains of 0.74 standard deviations in height for a z-score. So comparing that to what you're losing just by residing at a higher altitude, it tells you that the magnitude is quite high. On the next slide. Some limitations of our study. Of course, this is an observational study that benefited from a standardized nationally representative demographic and health survey. So because of the nature of the study design, we cannot make causal inferences. So we can only attribute this to our findings as associations between altitude and growth faltering. But it's important also to note that you are not able to run the golden standard randomized control trial to answer every question. Generating experimental evidence on this topic is very difficult, if not unfeasible, because that would then mean you're moving a set of randomly chosen population to live at a lower altitude or at a higher altitude and wait for some time to see the child being born, etc. So you can imagine all sorts of problems related to that. But instead, we attempted to control for as many confounding factors as possible, to adjust for as many confounding factors as possible, and triangulate our findings to mechanistic studies that used animal models so in sheep and rats, all sorts of animal models were used to evaluate chronic hypoxia and its impact on growth faltering. And our findings seems to be justified. Next slide. So as a summary, few points to note. One is children residing at higher altitude were on average born shorter and remained on a lower growth trajectory than children residing at lower altitude. The altitude-mediated growth deficits were biologically significant and applied even for children living in the ideal home environment. The perinatal period is the most vulnerable period. Fourth, given the possible functional deficit associated with altitude-mediated intrauterine growth restrictions, we do not recommend a downward adjustment. We think that the WHO growth standards equally apply here, so it does not need to be adjusted. Next, and fifth, specific healthcare guidance and monitoring may be needed for the management of pregnancies and early child development at a higher altitude. What we have today is advising pregnant women to not go at higher altitude areas during pregnancy. That's what you would find in the health literature in terms of guidance regarding high altitude pregnancies. Sixth, residence at higher altitude is one additional risk factor for linear growth faltering that may need to be considered. And finally, we think that failing to address altitude-mediated growth deficits may result in a significant proportion of the world population not meeting the SDG and the World Health Assembly nutrition targets. Thank you. You can find more about our study that is published in the JAMA Pediatrics and also open for questions. And thank you very much for your attention. Over to Cornelia.
Thank you very much, Dr. Kaliab and Dr. Jeff. These were two very, very insightful presentations. I would now like to call upon everybody to join us for the question and answer session today. So for those that have not yet done so, please put your questions in the question box. I will give you a little time to do that. And in the meantime, I ask also that Dr. Caleb opens his video cam so that we get ready for the Q&A session. Thank you. So please, everybody, shoot away questions in the question box. That would be wonderful. So I see there's a number of questions coming in. So I will start with a question for Dr. Jeff Leroy. I see Jeff has actually already responded to some questions to everybody, but there are some that came in that I would like to ask. So Dr. Jeff, Meron Girma from EPHI NIPN asked the question to you. Thank you for an interesting talk. Should stunting be used in global targets such as SDGs and WHAs as an outcome in the future, considering global stunting decline rates have stagnated and the etiology of stunting is not well understood? Is it a good marker? Over to you, Dr. Jeff.
Yeah, hi. This is an excellent question, and it's important to emphasize that yes, it is a very good marker to describe what is going wrong for populations of children. So looking at, and I had to go a bit fast in that part of the presentation, but when we look at the prevalence of stunting in a country, and we see that things improve over time, that the prevalence of stunting decreases over time, we can safely conclude that the situation for children in that country has been improving. Likewise, when we look at the north and the south of a country, or the east and the west, and we see that stunting rates are different between regions, we can also say that in this region, children do better than in this region. All to say that at the population level, it's a very useful marker. So by all means, at the global level, to track progress, we should be using it. Now that's different. The point I was trying to make is when we then try to address the problems of child development, of insufficient diets and so on, we should directly address those problems and not go through stunting to find our way to the causes of those problems. That's the point I was trying to make. Thank you.
Thank you very much, Dr. Leroy. Tupege Kasongwa from the NIPN, or the National Information Platform for Food and Nutrition in Kenya, also asked you a similar question, but then also a slightly different one. She says, by linear growth retardation, you mean growth below 0 SD. Is it right to believe that severe stunting, -3 SD, is associated with poor child development, reduced work capacity, and so forth? I know you've answered that question, but for the others, please go ahead.
Sure, happy to explain. So there's two parts to the question, right? The first one is that, again, emphasizing the importance of the population level. When you look at that distribution that I showed in the beginning, where we have the healthy population, and then shifted is the population in Burundi, you can see that that entire population has shifted in the wrong direction, which means that all of the children in this population suffer from growth retardation to some degree. So we should think of linear growth retardation much more as a population tool than something that tells us something about individual children. So that's the first. So we can't really define an exact cutoff to say, now this child suffers from linear growth retardation. We don't know that because nobody can read the genetics, the DNA of an individual child to see how tall would he or she have been in the absence of these problems. The second part of the answer is, yes, linear growth retardation and stunting are very strongly associated with child development with reduced work capacity. But an association is not the same as a causal link. So it's not because they're strongly associated that linear growth retardation is causing these problems. And that's the point we're trying to make here. Association is not causation. So if you want to address child development, you should come in with interventions that directly address early childhood development, and not hope that by fixing linear growth, you will also have an impact on early childhood development.
Thank you very much. A follow-up question to that, Dr. Leroy. Measuring linear growth in large-scale surveys is considerably easier than measuring some of these other outcomes you just suggested, such as early childhood development, nutrition status, and so on. Are these changes you are suggesting feasible?
Yeah, that's an excellent question. And we obviously, I agree that linear growth is fairly easy to measure. That's why we do it in large scale surveys, and that's what Kaliab was able to use. I mean, he has information on millions of children because it's a fairly easy thing to do. I think that our focus on linear growth retardation has slowed us down a little bit in thinking through how we can easily or more easily measure other outcomes. The good news is that there is some important developments happening right now. For instance, when we look at linear growth, early childhood development, some initiatives are underway to construct tools that would allow these outcomes to be measured in large-scale surveys. Also in other domains, there are some interesting developments happening. So I'm hopeful that these outcomes will become easier and easier to measure. But it's also, as more people try to do it, that we collectively learn and becomes kind of collectively easier to take those on board in our studies and surveys. So yes, it's easier, but to measure growth, but that doesn't mean that we should always fall back on growth as, you know, the only thing we measure. Thank you.
Thank you very much. My last question, or I mean, there are many questions, but let me ask the following one for you as well before I move over to Dr. Caleb. So there's a question that came in from Ursula Truxwasser. She says, stunting is used as an outcome measure, and many projects and policies have been putting a lot of effort on stunting reduction. How do we achieve the proposed paradigm shift? Sorry, now I've just lost the question. How do we achieve the proposed paradigm shift without losing policymakers and implementers' commitment in nutrition overall? To you, Dr. Jeff.
Excellent question, and I'm not sure I have the perfect answer for that question. I think it's a multi-dimensional effort. Part of the effort definitely is with the donor community, and I see some hopeful signs that the donors are thinking about using other outcomes to measure whether nutrition programs were effective, whether they were successful. So that's good. I've seen interesting and hopeful developments on the measurement side of things. And to kind of wrap up my answer, I'm at the risk of confusing people, but I would like to throw in another analogy to kind of drive home the message that something we care about at the aggregate level does not necessarily translate well in what we measure at the kind of program or policy level. When we take in economics, for instance, we look at the gross domestic product, GDP of countries, to kind of make an overall assessment of what the country produces. Now, if countries try to improve that by, say, you know, investing in education or in lowering taxes and so on, the outcomes they would look at would be much closer to the policies they're implementing, looking at educational levels, how many new companies were started, and so on. And then they would hope that in the aggregate over years, they would see an impact on GDP. I think for linear growth and stunting, we're looking at a similar thing. It's a very useful marker at the aggregate at the country population level, but when it comes to the specifics of what we do, we need to be much more specific at what we observe. This is my message. It's not an easy one, but I think by collectively, repeating it, we will slowly get where we need to be. Thank you.
Thank you very much, Dr. Jeff, for those answers. It definitely is not an easy one. So thank you very much for that. I will quickly shift gears and ask Dr. Caleb some of the questions that came in. So Dr. Caleb, we have Entene Omar from Hawassa University asking you, have you tried to look at the difference in or compare dietary intake of children between children living in lowland and highland by altitude? Over to you, Dr. Caleb.
Thank you. So what the dietary indicators that we have captured by the Demographic and Health Survey are dietary diversity score. So dietary diversity out of 7 food groups, now 8 food groups, including exclusive breastfeeding. We have exclusive breastfeeding as one marker, and then minimum meal frequency. So as a proxy for diet quality, in spite of the limitations, these indicators show provide quantity-related measures with the minimum meal frequency, as well as some quality level indicator with dietary diversity, where you would think that the more diverse the diet is, the higher the chance of it being fulfilling nutritional requirements. So with the limited available indicators that we had, we compared it by altitude. We haven't seen any difference globally. So from the global analysis, that doesn't mean that in specific countries you would not see it. Of course, you would expect with a difference in agroecology, and difference in production, etc., that would translate into difference in diet and diet quality measures. But without aggregate analysis, we haven't seen any significant difference that is using the minimum meal frequency and minimum diet diversity score. So it would be nice to see in which countries we see such difference and where it becomes important in a follow-up analysis.
Okay, thank you very much, Dr. Caleb. Another question again from Tupega Kasongwa from the NIPN in Kenya. Should we expect low birth weight at population level for children born in high altitude, or what is the perinatal effect of higher altitude on children? Over to you.
Yeah, okay, so our study, as well as earlier studies, have shown that there's a higher risk of the low birth weight at higher altitude, and major reason that is attributed to that is the constant deficit in the supply of oxygen, which would lead to chronic hypoxia, which is not an ideal situation, and whereby the fetus would respond to that by becoming smaller. So that's one contributor to low birth weight, but that's not the only one. So you've got poor nutrition, stress, so many factors come into play. But what we're highlighting here is, on top of all that, you also have the effect from the chronic hypoxia due to residence at higher altitude. So yes, we would expect a higher risk of low birth weight and linear intrauterine growth altering at higher altitude. An exception would be in areas where you have multiple generations living at higher altitude. Then you have some compensatory mechanisms through genetic adaptation that comes into play, but studies that compared populations living in Amhara region, for example, who are known to in Ethiopia, known to live in the highlands, or in Bolivia or in Tibet. You have different ways of adapting to this suboptimal environment of chronic hypoxia. So, yeah, in general, I think at the population level, we would expect a higher risk of low birth weight and growth faltering.
Okay, thank you, Dr. Khaled. I don't know if you or I are breaking up, but I'd like to pose you another question. Bridget Fenn from C4N, so Communications for Nutrition, asked the question. You've alluded to this, but maybe you can answer in more detail. Should we be adjusting our population global levels of numbers of stunted children due to altitude? If so, any idea by how much?
Yeah, so when we started the study, that was the driving question. Do we need some form of adaptation of the WHO growth standards for residents at higher altitude, or not? Our findings lead us to think that the growth faltering that we are seeing is particularly attributed to complicated pregnancies. It's already happening at birth, and so and then if you're looking at linking it to the literature and what goes on during pregnancy at higher altitude, then chronic hypoxia comes in, and that's not going to just lead to shorter height, but we expect more serious functional deficits, because it would mean limited oxygen going to the brain, limited oxygen, and so in a way to respond to that situation, cardiac output increases, so irregularities are expected on that. So and then there are studies that related chronic hypoxia related intrauterine growth restriction to cognitive deficits and so on. So if in the future we could get indicators, early child development indicators, as Dr. Blohoa mentioned, being easily captured in large surveys like Demographic and Health Survey, that would give us the opportunity to substantiate further that it's not just a physical growth issue, it's more than that, it's associated with functional deficit. So if we agree that it could be linked to a functional deficit, you would want to play around with the growth standards, but instead solve the problem, the origin, the source of the problem. And so we do not recommend a readjustment of the WHO growth standards. We instead recommend that we do research as quickly as possible, and to understand mechanisms and understand in what circumstances you get to compensate for this chronic hypoxia, looking at genetic adaptation, etc., to come up with interventions that help pregnancies at higher altitude. Yeah, so that's what we.
Okay, thank you very much, Dr. Khaled. I think we are coming to the end of our Q&A session. I do have one quick question for you. How do you see the impact of global warming on linear growth and functional capacity? This is from Endala Mautesema.
That would be a nice study, the follow-up, a nice study that we could, look at it further. But I haven't done much on this. But definitely you would expect that there are pathways whereby it could affect diet quality. There are studies that linked climate change to lower nutrient composition in some of the major crops, staple crops. You've got more adverse events, and that could also exacerbate seasonality of undernutrition in low and middle income countries. So you would expect that there would be a negative effect with climate change. We've got examples from the El Nino droughts in Ethiopia and other places that was linked to undernutrition. But yeah, that would be a nice study.
Yeah, if I could come in on that question. Well, Cornelia, you didn't direct it to me, but I'll jump in anyway.
That's good.
Yeah, I would just want to, I strongly agree with Kaliab that I think there's a lot of evidence that these changes in the environment have severe impacts on what people can produce, the price of healthy foods, and so on. So to me, the question is not so much, will this have an impact on the linear growth of children? What we as a global nutrition community or global community, global development community are concerned about, or what we want to see, is that all children lead happy, healthy, productive lives. I mean, they develop into adults that can contribute to societies and be creative and be better off than their parents. And I think that will be more of a struggle for the coming generations because of global warming than it was for current generations. So that's what we should be concerned about, and not so much whether it has effects on linear growth of children. That's just my 2 cents on that question.
Thank you very much. I don't know, Dr. Kaliab, do you want to add another 2 cents before we move on and close our Q&A session?
No, just thank you for the stimulating questions and for making it possible to present.
Okay, well, we are actually now at time and we are at the end of our Q&A session. There are many questions still in the question box. Some have already been responded to, others not. I see one of our participants mentioned that the internet is becoming too poor for her to follow, but please be mindful. We will actually write up the Q&A session, and if there are any unanswered questions, I will kindly ask our speakers to respond to those as well. So thank you very much. I think this was a very good conversation. We are at time, so I will now end the Q&A session. Thank you very much for Dr. Jeff and Caleb for your participation. Before I close, as I said as a reminder at the beginning, the webinar will be recorded. The Q&A will be written up, and we will share these presentations through our NIPN website, which you can see here on the last slide. There's also the NIPN email address, the email address of our 2 speakers. They were kind enough to share those with us as well. You can also find their studies, as they indicated, on the presentations, which we will be sharing, and more information. So I'd like to thank Dr. Aregash, the NIPN, EPHI, and IFPRI teams, and the organizers for this event. Thank you very much for hosting us. To our speakers, thanks for sharing your knowledge and taking the time to share these findings with us and responding to our questions. To the participants, thank you very much for your engagement throughout this webinar. We're always very happy to have you. Thanks for your provocative and engaging questions. I also would like to just say thank you to our donors, the EU delegation for Ethiopia, the Foreign Commonwealth and Development Office, Bill and Melinda Gates Foundation. Without you, we wouldn't make this possible. So I will now close this meeting. Thank you very much for everyone, and we look forward to seeing you at our next webinar, which is in December. Thank you very much, everyone. Have a very good day.